Good afternoon, everyone, and thank you for joining us today. My name is Ashley Breath, and I am a program manager on the DSH Diversion team and will be moderating today's webinar. I have a few housekeeping items for the group before we get started. First off, we have automatically muted all of our participants when they join the meeting, and we ask that you please remain on mute during the webinar. We will be taking questions at the end of the presentation today, and we ask that if you do have questions to please use the chat box at the bottom of your screen to send those in to us. And please feel free to send them in throughout the course of the webinar, and we will respond to those at the end. If there are any questions that we cannot get to just because of time constraints or because we don't have the right person with us to respond to the particular question, we will respond to those in writing after the training. Now I'd like to introduce you to our speaker today, Dr. Sean Evans. Dr. Evans is a licensed clinical forensic psychologist with a PhD and MA in clinical psychology from Loma Linda University. Dr. Evans completed his clinical internship at Patton State Hospital. Following his internship year, he was hired as a staff psychologist and eventually achieved the rank of senior psychologist supervisor. Dr. Evans left full-time employment at DSH to pursue academia, achieving the rank of tenured associate professor and department chair for 9 years. He returned to full-time DSH employment last year, serving in the Office of Clinical Research and Program Implementation. In addition to this work, he supervises forensic psychology postdoctoral fellows at Patton State Hospital. Dr. Evans has provided a variety of forensic psychological services, including violence risk assessment, sex offender recidivism risk assessment and treatment, as well as competency to stand trial, criminal insanity, and mentally disordered offender evaluations. His research interests include violence risk assessment, severe mental illness and violence, situational factors associated with violence, and psychopathy. Thank you, Dr. Evans, for joining us today.
Thank you so much, and thank you for that introduction. I hope you can all hear me all right. So I have a confession to make, full disclosure. This is my first time using this format. I am more comfortable speaking in front of live audiences. So if I were to use like a band metaphor, I am more of a Grateful Dead or Fish or Pearl Jam or Rush, less of a studio band. So anyways, this is a new format, and I feel very fortunate to be able to give this lecture. So I'm going to go ahead and start off by kind of discussing, I'm going to provide today just a really brief overview of risk assessments. And throughout the talk, I will focus at times on violence risk assessment, since that is my area of expertise and interest. But really, what we're talking about is risk assessment in general. So whatever those adverse outcomes that one is interested in, this sort of applies to that. So I get asked, and people often ask questions such as, what do we mean by risk assessments? What is the purpose of risk assessments? And also, how do we mitigate or manage risk? So for this talk, I'm basically going to focus on these three questions and use them to kind of guide my overall discussion. So what do we mean by risk assessments? The work that we do and the populations that we work with are very complicated. They're very complex. And a lot of the things that we are making decisions about are uncertain. So we need a frame. We need some sort of framework to help us. Risk assessment is really ultimately an uncertainty assessment. It's helping us understand what we don't know, not what we already know. So risk assessment is not an exercise in confirmation bias. It's really an exercise in helping us to understand things. And I think the philosopher Donald Rumsfeld, who some of you may know or not know, I think kind of conceptualized this concept well when he famously talked about there being, for instance, known knowns. And known knowns are things that we know that we know. So these are things that we know that we already know. So for instance, an example of this is, I know where I'm at today. I know I'm in the state of California. I know I'm in my office giving a talk. These are things that I know that I know that I know. He went on to talk about known unknowns, and these are things that we know that we do not know. Like, for instance, I don't know how many people are listening to this talk right now. I don't know the population of Austin, Texas. And I know that I don't know these things. So these would be known unknowns. He went on to talk about unknown unknowns. And these are things that we do not know and that we don't even know that we don't know these. So these are things that are beyond our horizons of knowledge and awareness and so forth. I can't even give you an example because I can't even think of something that I don't know. Interestingly, he sort of forgot, I think, a really important category, which you may have already guessed it, is the unknown known. And these are things that we know, but we do not know that we know them. And when we really get down to it, this is the place of bias and cognitive error. And this becomes really important when we're making decisions, especially highly consequential decisions. And because of the complexity and uncertainty of risk assessment, this really puts an upper limit on our predictive and preventative ability to know and to intervene. So we need tools that are going to help illuminate the unknown unknowns, the things that we're not even aware of, and keep in check the unknown knowns, the things that may bias or interfere with good decisions. So we need a frame. And the frame that I'm going to offer you today is formed by what is known as the risk need responsivity model, the R&R model. Another element of this frame is really talking about empirically supported approaches, risk assessment, instruments, and so forth. So I'm going to focus mostly on actuarial and structured professional judgment. And then finally, a model known as the service referral matrix. And this is going to kind of guide the frame that we're going to talk about today. So the R&R model, which was developed quite a while ago by Andrews and Bonta, was really developed to provide a framework for the assessment and management of offenders in various forensic populations. And it's really premised on three principles. The first is what's known as the risk principle. And the basic idea behind this is that the level of intervention needs to match the individual's risk level. So a person or an individual that has been determined to be of, let's say, high risk needs to be getting and receiving interventions, monitoring, and so on at a level that is commensurate with that level of risk. Individuals at low risk should not be receiving the same level of intervention and monitoring as someone at high risk. So level of intervention really needs to match the individual's risk level. The need principle is the next one, and this really is about targeting individual risk factors that are relevant to risk adverse outcomes. So this is really about focusing risk factors that are relevant to that particular individual. So not everyone needs anger management. Not everyone needs substance use treatment. Individuals where those are of relevance do sort of warrant that kind of intervention or treatment. And finally, the third one is the responsivity principle, which really takes into account factors that can affect treatment outcomes. So these can be individual factors, dispositional factors, such as if an individual has some sort of cognitive impairment, some sort of disability, some sort of language barrier, and so on, but as well as motivation and so on. But this also really includes like strengths of the individual or the patient. And so really we want to be able to take into account those factors and tailor our interventions for those sort of unique qualities. So I'm going to talk a little bit about violence for just a minute. And again, so when we talk about risk assessment, we can talk about really any sort of adverse outcome, reoffense, and so forth. I just want to mention violence really quick. So as you likely know from the statutory language, for this mental health diversion program, participants are only eligible if they, quote unquote, do not pose an unreasonable danger to public safety. So this is the piece that, you know, we're kind of delving into when we're talking about violence risk assessment. So first of all, violence is really difficult to define. There's lots of debate about what exactly do we mean by violence. Sort of the kind of definition that's used often in the literature and in the clinical forensic world is violence is the actual, attempted or threatened physical harm of another person that is deliberate and non-consenting. So a couple of things to keep in mind. Violence is a behavior that is observable, it's measurable, and it's changeable. So it's something that we can observe, it's something we can measure, and it's ultimately something we can change. I think it's also really important to mention that violence can be actual, it can also be attempted, it can also be threatened. So there's lots of different ways in which that can manifest itself. Another really important part of violence is intent. Sometimes intent is easy to identify and sometimes it's not. But violence is always a means to an end. And sort of understanding what that intent is an important part of this type of risk assessment. And finally, violence is a consequence of a variety of biological, psychological, and sociological factors. And although we may not have anticipated violence, it is a consequence of a bunch of correlates that precede that violent event. There's sort of a line that's oftentimes people use when they talk about sort of an event that came out of nowhere, that's kind of out of the blue, out of the blue, this individual committed this act of violence. When we sort of look at it and sort of break it down, there are usually correlates that we may have known and sort of misinterpreted. There may be things that kind of fall into that unknown category that we didn't even realize were relevant. And so this is where, again, violence risk assessment kind of helps us sort of know these things. I've heard a famous forensic psychologist, Joel Duboskin, say, if you're ever in the blue, get the heck out of there because bad things seem to happen in the blue. So don't stay there for too long. I'm going to kind of break down violence risk assessment into its components. So let's talk now about risk really briefly. What do we mean by risk? Risk is a threat of hazard that is incompletely understood and thus whose occurrence can be forecast only with uncertainty. I mentioned a moment ago about the consequence of violence as being a biological, psychological, and sociological phenomena. It's very complex. It's multifaceted. Violence is also highly contextual. Even the most violent individuals are not violent all the time. And so violence is highly context-specific and contingent. So one of the ideas here is that if you can change the context, you can change the risk. And so that's, I think, a really important thing. And, we may not be comfortable with this concept, but the reality is because we're engaging in forecasting into the future, it's always speculative. And this is just an inherent part of what we do. And so really what we need is a methodology that's going to improve those predictions and those assessments of what is to come. Assessment is a really fancy word for basically gathering information for use in decision-making. It's always purpose-driven, and I'm going to talk a little bit in a minute about kind of the purpose of risk assessment and what we mean by that. It's case-driven, which means, we know a lot in the research literature about violence sort of in general, but really what we're doing with risk assessment and violence risk assessment is we're really trying to figure out, but how does that information apply to this individual? So it's always case-driven, which means that we're really interested in bridging those gaps between what we know sort of in the literature and among groups and applying those to this particular individual. And of course, it's multi-perspective. I know that a lot of people listening to this come from various backgrounds and disciplines and professions. All of that information is really rich and important when we're doing any sort of assessment. So it's always multi-perspective in its approach. And finally, I kind of slipped management in here. This is a really important concept. I can't even think of risk assessment without thinking of management, because at the end of the day, what's the point of doing any sort of assessment if it's not going to lead to some sort of mitigation or management of risk? And so management really here is the process of taking action to gain or maintain control of a situation. So this means that it's active, it's ongoing, and I'm going to talk more about this a little bit later. What we learn and what we gather from the assessment is really going to help us in determining kind of an overall broad strategy for reducing risk, and again, if we're talking about violence or whatever. It may involve sort of pharmacological interventions, which are going to target obviously more biological causes. It may involve cognitive and emotional therapies, which will, target more psychological root causes. And it may involve changing the context, which is more of kind of those social or sociological or situational factors. So it's strategic, but then also, again, if we're kind of looping back in that R&R model, that responsivity principle, we really want specific tactics or interventions that are part of that overarching strategy that are going to be relevant and useful for that particular individual that we're working with, that it really targets those particular risk issues. So what is the purpose of risk assessments? Really, to boil it down and to make it super simple, it's really about guiding how we make decisions regarding risk. And really what it comes down to is identifying empirically supported risk factors. So when we get to the essence of what's the purpose of risk assessment, it's about identifying risk factors. So of course, what is a risk factor? A risk factor is a correlate that also precedes the occurrence of the hazard and therefore may play a causal role. So that's kind of a mouthful definition. Let's break it down. So one thing that I think is kind of useful to think about is this word factor. So factor and the word factory have the same roots. And if you think about what a factory does, factories make things. So what a factor does is it makes something. It makes a risk occur. So a risk factor is something, a correlate, something that's associated that precedes the occurrence of whatever that hazard or that outcome that we're looking at. So it's really important to note right here that not everything is a risk factor. There are a lot of things that we refer to or people refer to as risk factors that actually do not fit this definition of what a risk factor is. So it's important to be really clear that when we talk about risk factors, we really want to rely upon factors that have been, studied and found to be actually predictive of actual violence or whatever that outcome is. I also want to mention really quick, there are different types of risk factors. There are risk factors that are sometimes referred to as fixed, historical, or static. These are risk factors that do not change over time. So, for instance, your sex, your history of previous violence, how many times you've been arrested, whether or not your parents were divorced at a young age, all of these things have happened in the past. You can't change your past. These are fixed historical risk factors. Dynamic or variable risk factors, on the other hand, do have the ability to change over time. And some examples of this are substance use, symptoms of a mental illness, and so forth, treatment responsivity. So those are some examples of dynamic risk factors. As we'll talk about later, some approaches to risk assessment focus more on historical or static factors, while others may focus on dynamic. And some instruments really incorporate both. And we'll talk about that in a little bit. All right, so what is the purpose of risk assessment? So the purpose of risk assessment, like I said, it's really about identifying risk factors to help guide our decision, in determining sort of what to do with an individual in our various systems that we're working in. So one of the things that I think is an important sort of distinction is this idea of predicting versus preventing. Some instruments and some approaches to risk assessment really fall more on that prediction side. They tend to be more the actuarial risk assessment instruments, whereas others really emphasize more of prevention and more of that management element. And so, again, we'll talk more about that in a little bit, but you will see with the various approaches that there tends to be kind of an emphasis in one approach or the other. So I want to talk very quickly about the oldest approach to risk assessment, in particular violence risk assessment. It's one that has many names. The common name is unstructured clinical judgment. And this is a process characterized as one which, and I'll just quote this famous Grove and Mule quote, it relies on an informal, in the head, impressionistic, subjective conclusion reached somehow by a human clinical judge. So basically, unstructured clinical judgment is, so first of all, it's the most commonly used process for assessing violence and assessing risk. It's really impressionistic, which means there really is no formal sort of methodology or approach. It's really about sort of, using your clinical judgment without a methodical procedure. So let's kind of apply unstructured clinical judgment to a real case scenario. So let's say this individual comes into your system. He obviously looks like he's got a jaded past. By the way, I love this little advertisement. If you look at the bottom, it's called for pacifiers for difficult little people. So you see this individual, you start forming an impression. You see the tattoos, the piercings. You find out that he wets his bed. He indiscriminately hits people. He has even been reported to strike his parents. He has hit animals. He once got a hold of some matches. So, trouble, right? Actually, there was a time where a lot of these things that I just mentioned were considered risk factors. There was a time where tattoos were a sign of gang involvement. These things have not really panned out to be great predictors of risk for violence. Pretty much everyone has tattoos. So these are not really, there's not great empirical basis for this. A famous psychologist, John Monahan, did a seminal study in the 80s where he looked at unstructured clinical judgment. And basically the take home of this slide is that psychiatrists and psychologists were accurate, and you probably have heard this is kind of a famous study. They were accurate in no more than 1 out of 3 predictions of violent behavior over a several-year period when using this approach. So basically, it would be more effective to flip a coin because the odds of flipping a coin are 50-50, whereas using this approach, it's about a 1 out of 3. So unstructured clinical judgment has really been heavily criticized as a not great approach, and yet it still is the most commonly used approach for risk assessment. So as you see here in the evolution of risk assessment, we started with unstructured clinical judgment, and from there developed into actuarial decision-making, which is quantitative, algorithmic. This is basically the same approach that insurance companies use to predict risk. It's again, created by, predictive modeling and statistical analysis that comes up with factors that predict. No sort of clinical decision-making is involved in that. It's basically you rate it, you score it, you code it, it gives you an estimate of risk. From that was developed the structured professional judgment, or SPJ. And what this really brings together is both clinical and actuarial sort of approaches. So structured professional judgment incorporates both what we know in terms of, empirically supportive predictors of risk, but also allows clinicians to use their expertise and training to guide that. And really, it helps sort of develop a comprehensive and individualized set of risk factors. And I just put up here some examples of some actuarial assessment tools. You'll see at the bottom right, the Violence Risk Appraisal Guide is probably one of the most well-known. It's also referred to as the VRAG. The Static 99 is an instrument used for sexual violence risk and so forth. I'm going to talk a little bit about structured professional judgment. I was kind of already discussing that in a bit a moment ago, but it really is this discretionary approach where decision-making is assisted by guidelines that really are developed to reflect the state of the discipline with respect to scientific knowledge and professional practice. One of the great things about SPJ is that you could have just one risk factor. Let's say a person has violent ideation. They say, after this evaluation, I'm going to go out and commit these acts of violence. That may be just one risk factor that's present. However, that is a really serious risk factor that may elevate a person's risk to high, even though it only involves one risk factor. Again, this kind of, the SPJ approach kind of allows more for that decision-making, whereas actuarial tools, if followed to the standard of practice, don't really afford that kind of that judgment. And these are some examples of structured professional judgment tools. The historical clinical risk 20, also known as the HCR 20, is considered the kind of the gold standard in the in the field. Another one is the short-term assessment of risk and treatability, or the START is another one. But there's a variety of SPJ tools. And I'm just going to use the kind of SPJ framework for a minute to kind of provide an overview of the structured violence risk assessment process. And it basically falls into three big categories. The first, with 7 steps. The first is identifying facts. So one of the things we do in assessment is we gather information. We may interview the individual. We may look at available court records, whatever documents are available. So we gather information. Step 2 then is really to go through using an instrument with clear guidelines and definitions and rate the presence of risk factors. The next kind of category involves making meaning. And this is really steps 3, 4, and 5. And this is where we start looking at the relevance of the risk factors for this individual. A person may have, let's say, out of, 20 risk factors, they may have 8 risk factors that are present. But 3 of them are highly relevant to this particular individual. Let's say, for instance, mental illness, substance use, and a history of violence are really relevant. So one of the things that we do with risk assessment is we identify which things are relevant that we really need to target intervention and mitigation for. And also with SPJ process, we also develop case formulations where we really do an analysis of root causes, and we also develop different sort of scenarios to think about how we're going to manage and make meaning of this person's pathway to violence. The last group is taking action, and this really involves management and final risk rating opinions. So if we were to simplify this into 3 things, really what we're talking about here with this process is, first, what is the person's pathway to violence? Why has this individual perpetrated violence in the way that they have done in the past? So really, steps 1 through 4 are about trying to understand that. What is that person's pathway to violence? Next, we sort of, the process involves asking ourselves, what are we worried about this person doing in the future? If we're talking about violence or some sort of self-harm or reoffending, what are we worried about this person doing in the future? And that really involves those steps 5 and 7. And then finally, arguably, one of the most important steps in this is, what are we going to do about it? That's step 6 when we're talking about management. And I had mentioned the HCR 20 a minute ago. I really like this framework because it just provides a great sort of way of thinking about, again, violence risk using past, present, and future. So you have historical items there. The HCR 20 has 10 empirically supported predictive risk factors, as well as 5 clinical or dynamic risk factors that are really focused on what is going on with this individual in the last, say, 6 months. And so those can include things like insights, violent ideation, symptoms of a major mental disorder, instability, and so forth. And then finally, also looking into the future with risk management, future problems with living situation, personal support, stress and coping, and so forth. So this provides, I think, a really nice frame to really kind of conceptualize and think about, risk for violence that I think is super useful. And really, when we're talking about, again, the purpose of risk assessment, the goals are prevention, to guide and coordinate interventions. There's no point in doing there's a lot of resource and time that it takes to do assessment. There's no point in doing that if it doesn't lead to some sort of intervention that's going to mitigate risk, that's going to lower the risk of bad outcomes occurring. It also provides accountability, which allows us to reevaluate our approaches, to reevaluate what we're doing so that we can improve the consistency of our decision making. And finally, another goal is protection, community safety, and minimizing our own liability exposure. You know, this is the standard using actuarial or structured professional judgment. This is the standard of practice within the field. So following this approach or these approaches helps minimize our own liabilities. So the next question, how do we mitigate or manage risk? So I've mentioned before that I don't think you can really conceptualize risk assessment without risk management. They really are two sides of the same coin. Risk assessment, the process of speculating about whatever that outcome that we're interested in, violence, let's say risk posed by a perpetrator. And risk management is really this process of mitigating the violence risk posed by that perpetrator. So it's two sides of the same coin. And one thing that I like to mention here is that risk assessment and management is a process. It's not an event. I'm going to say that one more time because it's really important. Risk assessment and management is a process. It's not an event. It's not something that you do one time and then like you put it in some chart or in some file and then you're done. It's an ongoing process. It's something that we continue to do. It's an ongoing process of assessing, developing management strategies and tactics, and then reassessing and recalibrating and doing that on and on. It's a process that is ongoing. It's not an event. I was mentioning earlier, and this is kind of more of a structured professional judgment element, but case formulation is really, really important. And I recognize that some of the systems that people work in, the volume is just so huge. And so doing something like a case formulation, you know, it's great, but it may not be something that is easily done on like a huge number of individuals. So sometimes what can occur, sort of a strategy for that, is to develop either some sort of screening process or some sort of triage that allows you to determine sort of risk just very quickly. You know, usually like some sort of actuarial tool can be used for that. And then saving kind of the more complex, uncertain, you know, individuals and assessments for something like a structured professional judgment approach, which incorporates case formulation. And case formulation is this process. It's also it results in a product of gathering and integrating diverse information to develop a conceptualization of a person's propensity for violence that incorporates an orientation towards intervention. So case formulation is really about, if you remember that sort of simplified process, it's really about how, you know, what is this individual's, you know, pathway to violence? You know, what are the root causes of what they've done in the past? What are we worried about them doing in the future? And then what are we going to do to manage that? So a good case formulation has got to be practical. This is not a place, so even though it's theory driven and there's lots of different sort of theories and approaches to help with case formulation, this is not a sort of high-minded ivory tower academic exercise. This has to be practical. These have to result in practical solutions. And it really needs to be strategic in the sense that it really targets those things that are relevant to that individual. And I'm just going to mention very briefly risk scenarios. Risk scenarios are also kind of a core part of structured professional judgment with using either like the START or the HCR20. And really risk scenarios, kind of similar to case formulation, they provide a future-oriented formulation to assist with management strategies and really speculate about outcomes. Risk scenarios are kind of new to the world of violence risk assessment, but they're strategies that have been used for a very long time in business and in the military to kind of sort of think about possible outcomes and interventions. So one thing I like to say about risk scenarios is this isn't like some sort of, you know, FBI profiling or something like that where you're, you know, saying, oh, this is, you know, what I think will happen. It's really a speculative approach to conceptualize management strategies to, again, think about sort of the unknown unknowns, the things that, you know, we didn't even see coming that could be possible twists and so forth. So developing scenarios, evaluating scenarios, and using scenarios are really important for developing different strategies. And really what happens at the end of a risk assessment is you come up with summary risk ratings. And again, I'm kind of using a HCR20 here framework, but really coming up with that risk for future violence. And what I like, again, about the SPJ approach and the HCR20 is, it also really highlights not only sort of risk, but also case prioritization. So if a person is high risk, this also means that this is an urgent case priority. This individual needs to be sort of the focus of, treatment that is commensurate, and that treatment needs to be commensurate with their risk level. We also need to conceptualize serious physical harm. A person may be often violent, but the seriousness of that harm is relatively low. A person could be very, very rarely violent. However, when they are, the seriousness of that violent event or that outcome is really severe. So that's another thing that's important to think about in that kind of final conceptualization. Another thing we need to think about is imminent risk. I mean, are we worried about the possibility of someone being violent over the next 5, 10 years, or are we worried about them being violent in 5 minutes, 10 minutes, 24 hours? And so this is really what we're talking about when we talk about imminent violence. And it's always great to think about, again, if you go back to this idea of it being a process, when would be a good time to kind of reassess and reevaluate, particularly for those dynamic clinical factors as well as those risk management factors, to really think about what has changed either for the better or for the worse, and kind of reassess their overall risk ratings, but then also what kind of interventions and strategies we're using. So I talked about in the beginning kind of the third component of that frame, and it's referred to as the service referral matrix, and it really comes out of some research by some researchers, Vincent Guy, Grisso. And basically, it was a matrix or a frame sort of developed to think about how we implement interventions following our risk assessments. And so the categories here, so this comes out of the HCR20. This may not be relevant to the systems you're working in. Like, for instance, I could imagine looking at monitoring and supervision and saying, like, those are kind of the same thing. What we mean by monitoring is something like, repeated assessments, direct observation. So this could be like checking in with a counselor more frequently. The frequency is going to be contingent upon that level of risk. Supervision, this may be more, in terms of like probation, frequency of visits with their probation officer, what kind of limitations in terms of access to drinking, curfews, all of those kinds of things. Treatment, is another component of this. So again, kind of what kind of focused treatments and so forth. And then if we're talking about, victim safety planning, really thinking about who are the likely victims, and really enhancing any sort of resources or security for identifiable victims. So this next slide is kind of an integration of two slides you've already seen. So this is kind of the using kind of an HCR20 framework with the service referral matrix, and really also the R&R model, right? Because what you see here is that, again, the level of risk, if we go back to that risk principle, the level of intervention really needs to match the individual's risk level. So individuals that are at high risk or that are urgent in our prioritization, they should be receiving the highest levels of monitoring, treatment, supervision, and so forth. And that treatment needs to really be targeted towards risk factors that are relevant towards that for that individual. Like I was saying earlier, not everyone needs anger management, but if anger management is a risk factor for that individual, that absolutely should be part of that. So again, monitoring could be increased observation, repeated assessments. Treatment could be more risk-focused treatments, cognitive behavioral, dialectical behavioral, different cognitive remediation, and so forth. Supervision could involve some sort of imposition of controls, restricted access or freedoms, more frequent visits with the probation officer, and so on and so on. So what I've done, hopefully successfully today, is to provide a framework. And again, this is like a very introductory sort of lecture that provides a framework for thinking about very complex and uncertain phenomena that we're doing our best to try to make decisions about that are going to, lower, again, future risk, that are going to lower future bad outcomes and so forth. And again, there's lots of things that could be discussed. Each one of these elements, you could do a 2-day workshop on. But hopefully what this does is just provide some sort of framework to start thinking about things, in terms of assessing for various types of risk. So that is what I had to share. I understand that there's some time for some questions. So if there are any questions, I would love to hear them.
Thank you, Dr. Evans. Hi, everybody. This is Ashley Breath again. So if you could please, if you do have questions, send them into through the chat box feature, and we will get those to Dr. Evans. We had a few that came in during the talk. So question number 1 is, can you talk more about what you mean when you say that using measures decreases your liability?
Yeah, so here's the thing. I mean, forecasting is always speculative. Whether we're talking about weather forecasting or predicting human behavior, there's always a speculative element. You can only be held to the standard of your profession. Bad outcomes, are hopefully not common, but they can occur. And, at least within like my profession, really what you're going to be held accountable to is, did you follow the standard of practice? And when it comes to, let's say, violence risk assessment, actuarial risk assessments, and even more so now, structured professional judgment approaches are really considered kind of the standard of practice with this. So, using either one of those, again, my bias, I'm more of a structured professional judgment approach. I use that approach in my work. I think it just provides another level of defensibility in terms of what we did. This is the state of the art. This is the state of science in terms of doing what we do. And if the incredibly unfortunate sort of hopefully unlikely event of a bad outcome, if we followed these approaches and we followed them to the way they were designed and standardized, then I think we have a more defensible position to stand on. As opposed to, again, unstructured clinical judgment, it's the most common, but the research on it is not promising.
Okay. A second question. How do you decide what supervision or monitoring each person needs? I understand you take the information from the assessment, but how do you individualize the strategies?
Yeah, that's a great question. So I'm going to already disappoint whoever asked that question and say, so there is no kind of, one-size-fits-all answer for that. I think you want to come up with kind of an overall strategy, an overarching strategy that really incorporates kind of the root causes of a person's pathway to violence or whatever, again, that outcome we're looking at. Like for instance, let's say we have an individual who substance use exacerbates the symptoms of their major mental illness, and that normally their symptoms are held, they're stabilized and they're functional. But when they start using substance use, when they start engaging in substance use, it exacerbates those symptoms. Maybe they start engaging in sort of faulty thinking, and they start thinking, I don't really need to take these meds anymore. And it just kind of sends them into this spiral. Thinking about monitoring and supervision, I mean, right off the bat with this scenario, I would think monitoring and supervising substance use, maybe random drug screens, if that's possible, different sort of visits with, probation or whatnot, more frequent, engagement with their counselors, and so on. So that's kind of what I mean about, like, you really want to take that information and really think about, like, again, what's this individual's pathway to violence? What are we really worried about them doing in the future? And then how can we use these different sort of management approaches, whether it be monitoring or supervision, to help, again, decrease the risk or likelihood of that happening again. So one thing I've found, if you remember, like in my talk, I was talking about that risk assessment is kind of a multi-perspective process. This is where I think collaboration is really rich. I mean, there are so many professionals out there with a lot of experience, in these various things that, can provide different, sort of strategies and approaches that have worked well with certain individuals. So I think collaboration works really well, and just, really sharing with each other, like, kind of what has worked and what hasn't worked. So I know that probably doesn't answer your question, but that's those are my thoughts.
Okay. So we have a question on when the slides will be available for download. So I will be PDFing the slides and sending those out to folks who are registered for today's webinar by the end of the week. And then we will have the recording posted likely in the next 4 to 6 weeks on our DSH Diversion webpage. And I will send the link to that webpage out along with the when I send the slides out by the end of the week. Okay, couple more questions. What do you do if your county or department doesn't have resources to do a full risk assessment?
Yeah, so I think that's a very realistic. I think that's a great question. So a couple of thoughts. I think you do the best that you can. I know that there are tools that are very brief, that again are kind of more actuarial based. That can sort of more quickly screen some of these individuals. Yeah, I mean, I think the resource question is a very good one. So, full disclosure, I'm hyping the SPJ model. One of the limitations of the SPJ approach is it's time consuming and it's resource heavy. So, I mean, it takes a while to conduct a good comprehensive assessment using that sort of methodology, and that's not always realistic. So, I think the key is really, trying to reach out to, experts in the field who, may have some specific ideas about tools that have been used to help guide that decision making. And here's the thing, like, all of these approaches are really about improving decision making. And so anything that can help improve that is a step in the right direction. And, I think, figuring out if, what other counties are doing, what other like jail systems, are doing, like how they've used these different screeners to kind of identify, levels of risk and urgency and so forth. I think those are, I think that's sort of the approach I would take. I think there are others who have a better sense of what resources are available and so forth. So I may not be the best person to to answer this question, but, you know, I think any tool that helps move you in the direction of better decision making, you know, I think is a step in the right direction. But your comment and question about resources, I think, is a legitimate one. One thing I know that there's a lot of development right now in this area known as triaging. So, you know, triaging, you know, you may be more familiar with that, like in a medical sort of context. You know, the military medics have used triage for a long time to identify priority, and it's usually based on, you know, just a handful of things that sort of guide that decision. I know there's a tool that's been developed to guide that, and it's called the FIRST, and I'm of course blanking on it. I think it's the Fordham risk screening tool or something like that. I can find out and give the specific information about that, but that's a triage tool that's been developed and published. I know the creators of the HCR20, Stephen Hart and Kevin Douglas, are developing a triage tool. So I think there's realization of the need to develop, you know, a decision-making process that identifies individuals that are sort of at high risk, that need more attention, that can be used very quickly. So that would be my answer. And I'm sorry it wasn't probably did not provide the richness that you were hoping for, but I think you've identified a very legitimate challenge to implementing some of these things that hopefully, you know, we can work on collectively.
Hi, Sean, this is Darcy from DSH. I'll just jump in on that as well, because just to echo some of the things that you just said about resource limitations, that is, as Ashley and I have been talking with people at the counties, that question comes up all the time, and it's a great one. And so we are in the process of developing, you know, a list of kind of the best practices from other counties, and really getting flow charts and process flows from other counties that can help answer that question for others who are facing some of the same difficulties. So just to echo what you said, Sean, which is, you know, talking to people, not reinventing the wheel, talking to see what others have done, and that the use of any of these risk assessment tools, even if they are some of the shorter triage versions, really does help improve the choices that counties are making about who would be a good potential diversion candidate, but also, as you mentioned as well, reducing their own liability, or their county's liability, in ensuring that we're doing the best job possible for community safety.
Thanks, Darcy.
Okay, so we have, looks like we have one more question. What are some of the best mitigation or risk reduction strategies?
That's a great question. So, you know, there's a growing literature on that topic, and you know, individuals like Kevin Douglas and Stephen Hart out of Simon Fraser University are associated with a lot of that kind of work. You know, it really depends on the specific risk factor, right? So, like, you know, if we're talking about symptoms of a major mental illness, you know, pharmacological interventions are useful, cognitive behavioral therapy for psychosis. If we're talking about instability, you know, as a risk factor, you know, dialectical behavior therapy, specifically with some of the emotional regulation strategies, is super useful. You know, if we're talking about more of that sort of violent attitude, kind of pro-violent attitude, some of the work on criminogenic factors, I think, is really useful. You know, if we're talking about substance use as a risk factor, interventions that reduce that. You know, so I think it really depends on the specific risk factor. And I know there's a growing literature on empirically supported treatments that are effective for various risk factors. So, like if you search some of the names and the strategies and interventions that I mentioned, you'll be able to see like book chapters and stuff like that. So again, kind of going back to this case formulation idea, I mean, it's really about trying to understand again what those root causes are, what risk factors are really the root cause for that pathway of violence, and really coming up with interventions that are going to reduce or mitigate those things specifically. So each person is going to be obviously very different, and it may look like a slightly different configuration. But that's where I really come back to the R&R model and thinking about what are the risk needs, what are the, what are their risks, what are their needs and so forth, what kind of risk factors do we want to target specifically that are relevant to this individual, but also to the adverse outcomes and so forth. So I kind of think that this framework really kind of helps you create strategies and tactics that are going to be specific to the individual that you work with.
All right. Thank you, Dr. Evans. We still have a few minutes, so if there are any other questions out there and you want to quickly get them in, please type away. And I will just take a moment while people are maybe sending in their last questions to let everybody know that we do have a roster of other webinars that are in the works related to our DSH Diversion program. And that's going to include some webinars on procuring housing, program sustainability, and collaborative case management, as well as others. We will be announcing dates for those webinars shortly, so please stay tuned. We have some more good stuff coming out for you. And I also would like to just put out there that if there are particular trainings that you or your county could benefit from, please feel free to email us your suggestions at dshdiversion@dsh.ca.gov. We need your input to know what's needed out there. So if there's something that your county is really struggling with or feels could benefit from some technical assistance, please email those suggestions into us. And it doesn't look like we have any more questions coming in at this point. So I want to thank Dr. Evans for the wonderful presentation and thank everybody who was able to join us today. And we hope to see you all at our upcoming webinars. Have a wonderful afternoon.
Thank you very much for the opportunity. Have a great day.